Hello and welcome. Let's talk about anti-tubercular drugs. The principles of anti-TB therapy includes long treatment with large number of the actively multiplying bacilli should be killed, combinations should be given, and in case of the MDR, multi-drug resistant organisms, longer period should be done. Now, classification of the anti-TB drugs. On the basis of the activity, efficacy, and risk of toxicity, first-line drugs includes 5 drugs: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. The second-line drugs are amikacin, aminocyclosic acid, capreomycin, clofazimine, ciprofloxacin, levofloxacin, cycloserine, ethionamide, ofloxacin, rifabutin, and rifampicin. These are indicated only when they are resistant to first line, and these are more toxic, and these are less effective than first line. Now the recommended regimen is 6-month regimen with 4 drugs, and for next 4 months 2 drugs, and tablet pyridoxine should be added. A 9-month regimen includes 2 months isoniazid, rifampicin, ethambutol, 3 drugs, and for 7 months 2 drugs and tablet pyridoxine. A 12 months regimen includes twice weekly streptomycin, isoniazid, and daily isoniazid and thiacetazine. Dots may be given. Now, in case of the resistant organism, it is most difficult to cure due to slow growing organism and relatively resistant to antibiotic. So, why combination is used? To decrease the bacterial load, to prevent the emergence of the resistance, to decrease the individual toxicity of the drugs, and to broaden the spectrum. In case of the extrapulmonary TB, if surgery is possible, surgery is followed by anti-TB drugs. In case of the meningeal TB, isoniazid, rifampicin, pyrazinamide, and streptomycin are used. For TB, steroid is also used because to decrease injurious reaction of the tuberculoprotein to human being, decreasing inflammation, allows time for the chemotherapy to take effect, and patient feels better more quickly, and there is sense of well-being. Now, multi-drug resistant TB, because of the resistance of the 2 or more drugs like isoniazid and rifampicin, multi-drug resistant TB occurs. If resistance to both isoniazid and rifampicin is seen, then streptomycin or fluoroquine should be given. Now, isoniazid. It is a bactericidal drug. It can kill both intracellular and extracellular pathogens. It is very active. It is hydrogen of isonicotinic acid. It can be given orally and parenterally. It is rapidly absorbed from GIT. It can penetrate caseous tubercular lesion. It is acylated by to acetyl isoniazid by N-acetyltransferase, an enzyme found in liver, bowel mucosa, and kidney. Mechanism of action. It is a prodrug which is activated by mycobacterial catalase peroxidase and isoniazid. The active forms covalent complex with SL carrier protein and beta ketoacyl carrier protein synthetase, which inhibits mycolic acid synthesis, which is the essential component of the mycobacterial cell wall. It is therapeutically used for all lines of the TB and single therapy for the latent TB treatment. It is used prophylactically for close contacts of the active case of the pulmonary TB. Adverse effects includes allergic reactions like fever, rash, vasculitis, and SLE, nausea, vomiting, and hepatotoxicity. Peripheral neuropathy occurs. Hematological toxicity like leukopenia, eosinophilia, and thrombocytopenia, and CNS toxicity may be seen. Drug interaction includes carbamazine increases serum concentration, phenytoin decreases metabolism, so increases serum concentration, ketoconazole reduces concentration, and disulfiram coordination difficulties and psychosis may be seen. Now, rifampicin or rifampin. It is bactericidal. It can kill intercellular bacteria. It is well absorbed when given orally, and the serum half-life is 4 hours. The mechanism of action is that it binds to the beta subunit of the bacterial DNase-dependent RNA polymerase and inhibits RNA synthesis. It is clinically used for TB caused by mycobacterium, for atypical mycobacterial infection, in case of leprosy, or also in case of the prophylaxis, or for meningococcal carrier elimination, eradication of the staphylococcal carriers. It leads to harmless organ coloration of the urine, sweat, tears, and contact lens. rash, thrombocytopenia, nephritis, cholestatic jaundice, and flu-like syndrome. Ethambutol. It is bacteriostatic and water soluble. It is possible to enter CNS for this drug if meninges is inflamed. It inhibits mycobacterial arabinosyl transferases and thereby inhibits the synthesis of the arabinoglycan, which is the essential component of the mycobacterial cell wall synthesis. As a result, ethambutol inhibits cell wall synthesis. It is used for TB and TB meningitis. It leads to retrobulbar optic neuritis, where there is loss of the visual acuity and red-green color blindness. Hyperuricemia may be seen. Relative contraindication is that the children which are too young should not be to permit assessment of the visual acuity and the red-green color determination are contraindicated. Pyrazinamide. It is bactericidal and prodrug. It is only oral form is present, metabolized by the liver. It is converted to active pyrogenic acid by mycobacterial pyrazinamidase and kills mycobacteria. Inhibits tubercular bacilli at pH 5.5. So drug is taken up by the macrophages and kills intracellular bacteria, dormant bacteria residing within the acidic environment of the lysosome and macrophage. Clinically, it is used as a first-line therapy for TB. The effects include hepatotoxicity, which is the major effect, hyperuricemia, nausea, vomiting, drop fever. End of the topic.